on my watch. So good afternoon, everybody, and welcome to the third of our four-part series on opioid use disorder for licensed nursing home staff. My name is Stacy Coop, and I'm a quality improvement advisor for Superior Health Superior Health. And I'm also here with fellow advisors, Tony Kettner and Rachel Dibble. So they will be assisting today with this webinar. And before I introduce the speaker, I just want to cover a few housekeeping items. Make sure that you are on mute to avoid any background noise, and it's beneficial for everyone. And then feel free to put any comments or questions that you have in the chat. Tony's going to be monitoring the chat for us today. So just even if you have them at the time, just throw them in there and we will be sure to address them at the end. There will be time for questions and answers. And we will also review those and at the end, as well as the PowerPoint, if you wish to follow along, is in the chat for you to follow along with or print out. And then we do want you at the end, and I'll say this again, is to evaluate the series. It helps us improve, and also feel free to share with us any other topics you wish for us to include or provide education. And without further ado, I'm going to introduce Rachel Dibble as our presenter. Welcome, Rachel.
Thank you so much, Stacy, and for having me. And thank you so much for taking the time to join. I know that can be a difficult task at times. So my name is Rachel Dibble. I am by trade an adult primary care nurse practitioner. And then I furthered my education with a doctorate in geriatric nursing, particularly with end of life. So again, thank you, and we will begin. So the topic, of course, is supporting residents in nursing homes. We'll go back to the first slide for just 1 minute. Skilled nursing facilities with opioid use disorders. So this session is discussing the pathophysiology, the signs and symptoms of opioid overdose and withdrawal. That being said, I would like to umbrella the title with thoughts as I speak to the topic. The pathophysiology of an opioid overdose or use disorder or withdrawal. It is a physiological chemical imbalance in the brain. So we need to understand that this is a real manifestation in the brain. So let's think about it in those terms. And then furthermore, when we think about it that way, we can get into the signs and the symptoms and withdrawals, because interestingly enough, those same pathological happenings within the brain are happening in all steps of a drug being, say, prescribed, being used, tapered off, withdrawal, etc. So it's the same brain activity and areas that are being effective. So we'll go in now with the objectives. That being said, so increase knowledge about the pathophysiology of opiate receptors, evaluate signs and symptoms of opioid overdose, evaluate signs and symptoms and management of opioid overdose, and understand the use of naloxone. So here's just some background. We know, we hear of the epidemic, the crisis that's happening now, just in the world at large, if you will. So to give you just some data points, so opiates in general have been approved as an analgesia for nearly 70 years. Prescriptions for opioids have increased over the past 2 decades. So I think that's important to note. So that's the last 20 years. Drug overdose is the leading cause of accidental death in the U.S. So that's obviously increased if you were to look back in the 2 decades. And then more importantly, the CDC Centers for Disease Control estimates more than 1,000 emergency room visits per day related to misuse of opioids. And in that are 91 opioid deaths. So just with that data, and that's not robust data, there's the robust data is there. But if you just look at these very simple numbers, what that says to me then is, doing the quick math, that we're going to have from today, moving 1 year from today, 365,000 emergency room visits multiplied times 91. I can't do the math that quick on that, but that's the impact. That's what I want you to feel. So what do? There's a lot that we can do. Insofar as, and just hold on this slide for a second, the individual patient, we have to look at them as the whole patient, right? And we focus on what the issues are. But we also need to focus on and understand the dependence mechanisms, the neurobiology, and the addiction issues or dependence within our patient populations, particularly in the nursing home setting. Next slide, please. So pathophysiology, what happens? And I really feel strongly that when we understand what happens, we have a whole new idea of opioids in general, and then those that were in any area that we're dealing with patients that are on opioids, withdrawal or overdose, whatever the scenario can be, we have a better understanding. So on a very basic level, what is an opioid? An opioid is derived from the opium poppy plant. So it's from a plant. Opioids are substances that act on opiate receptors, and we have opioid receptors. So opioids work via endogenous opioid system. So acting as a potent agonist, so working with, not against, agonist to the mu receptor. What is the mu receptor? That is the major receptor that likes all of these things. I'll get more into that in a minute. So in that, we get a cascade of events, and this can get very cellular. I'm not going to do that. But the idea is that in the cascade of events, once the mu receptor is activated, we have a dopamine release. And what happens when that happens? We love it. We love it. We love it. We love it. We have it naturally. People who don't have to take medications, that can also be viewed as mental illness. So I'm plotting these little seeds along this talk because I want you to connect the dots, because in the center of all of this is patient. And then we have to deal with stigma. I can't in this amount of time get into all of it, but these are the things I want you to start thinking through in your critical thinking. You don't have to be a clinician to get this as well. Anyone can understand this because you're dealing with the major one receptor, right? Okay. So when the dopamine releases, you have a blockage of pain signals. So the brain's like, you're good. Dopamine's released. I have no more pain. Oh my goodness. And I feel awesome. That's what happens to everyone who takes an opioid, except if someone's mu receptor works a little differently, and we don't know that when we prescribe, right? Next slide, please. So pathophysiology and mechanisms of actions continued. So the opioid receptors, they're in your brain. So that's the excessive effect on the brain regulating respiratory rate. So again, key word, other than what I just talked about, the patho, I'm now worried about a respiratory rate, because all of that happens within your brain to tell your body to breathe. They're also located in your spinal cord and in your gut. So what happens during an overdose? You stop breathing. It's really as simple as that, because your receptor is in your brain. Your brain is saying, stop breathing, because that's what's being affected. And then you pass away. And it is that quick, and it is the body chemically saying what's happening, and then death is the outcome. Next slide, please. So I talked about agonists. So opioids, what can they do? They can work together, say with your dopamines. They can work against, they can be or in your pain, your partial agonists, and then they can be an agonist antagonist. So they can work both ways. So opioids lower perception of pain, again, through the receptors. So we decrease pain stimuli. The receptors stimulate, reduce the sensation of pain. So that's when the opioid has worked properly, hit the receptor, pain is reduced, and then it binds to those receptors. And that's how we can control pain. Next slide, please. So the main opioid receptors, they mediate the opioid effects. So depending on where it is in the brain, again, your personal brain chemistry will then dictate if your trajectory of an opioid, be it short-term, long-term, or you may not be able to get off them because of this imbalance. So the mu receptor, what does it do? It mediates. Its job is to mediate analgesia and euphoria and respiration depression, GI, motility, and dependence. That receptor does all of that, which is amazing. So it makes you breathe, it makes you feel good, it stops the pain, it moves my gut. So what happens with people who are on opioids who are not on a bowel regimen? That's why mobility or motility. That's why they get a bowel obstruction. So now we have a GABA receptor. What does that do? Same thing, mediates pain, but it's also diuresis, moesis, and dysphoria. Again, key, dysphoria, euphoria. See where we're going? When we're trying to do is manage pain, but this is how our brain works with opioids from the poppy seed plant. So I'm connecting these dots for us, okay? So now we have a delta receptor. So what does that do? Okay, that manages pain as well. Oh no, that inhibits dopamine release and cough suppression. So if we don't have dopamine at all, we organically produce it, we're going to feel probably pretty depressed and bad. So we have our sigma receptors. So this gives you the hallucinations, the dysphoria, the psychosis. More research is needed, but naloxone does not reverse opioid overdose on the sigma. That is all we know. Don't take that away as gospel. More research is absolutely needed. But what we do know on the mu, kappa, and delta, absolutely naloxone reverses it and doesn't hurt a patient. So I'm going to put you in this scenario.
Ring, ring, ring.
You are visiting a patient. You are potentially maybe a custodian. You are having something to do with the patient in a nursing home, the nutritionist. Fine. Why is this important to you? Well, if you happen to know that Mrs. Jones just broke her hip and she has started on pain medicine, and hypothetically, she is hallucinating, she has gotten terribly depressed, we may think about pain medicine because we're altering our brains when we're on pain medicine, right? Okay, next slide, please. So what are the signs and symptoms? We know through the receptors we are affecting our central nervous system, hence decreasing our respiration rate. So opiates are generalized central nervous system. That's why the epidemic is so bad, because it's the central, which means you get one shot. If it's too much, that's it, unless potentially you have naloxone. Again, so it's a depressant and can cause the following neuropsychiatric symptoms. Again, anyone can be aware of this. You don't have to have a license to see these things, right? That's when we need to raise our hands, particularly in nursing homes, because we could be looking also at falls in particular comes to mind. So try to think again global when when you think about these signs and symptoms. So we have anxiety, agitation, depression. I will highlight depression. The rates are incredibly high these days, I will say, particularly because of isolation, etc. You see it in the nursing homes and perhaps the sequelae of COVID. So that's affecting a lot of pain meds in here too, because we got to feel euphoric and we got to feel good. For those who have lost loved ones in a nursing home, and maybe didn't see anyone for a year, came out and they're gone. That's just a case scenario that I have seen in particular. Hallucinations, nightmares, and paranoia. Everyone can raise their hands on this. You don't have to know what it is. It's that there's a change of condition. Something's going on. And we don't want that person ending up in the ER because they will not get treated the way they need to get treated because potentially they don't have all the pieces to the puzzle of why this is happening. So there's a huge responsibility on everyone in a nursing home, but it will put the patient first. Next slide, please. So opioid toxicity, potential overdoses with the same things: lethargy, shallow bleeding, unresponsiveness, pinpoint pupils, nausea, vomiting, absent low, erratic pulse. That is if you're not sure, feel that pulse. And if it is thready or erratic, you need to get on the phone because that's something that we need help for. Absent, slow, erratic pulse, body appears limp and pale skin. But look at this. All of this mimics hypoglycemia or a potential MI. So we've got to be aware. In doubt, 911. Next slide, please. So I'm giving you the DSM-5 criteria for withdrawal because, again, withdrawal can also affect the mu receptor because we're not producing anymore. And that's the withdrawal. And withdrawal is life-threatening. So we have to be, prescribing, tapering, getting off opioids. It has to be done very, very cautiously and mindfully. So the DSM-5 has given us the diagnoses for opioid disorder. So or withdrawal rather. So it includes lacrimation or rhinorrhea, and that's just really watery eyes and just your nose is just running, won't stop. When you have goosebumps or goose flesh, piloerection, myalgia, nausea, vomiting, diarrhea, some photophobia, and pupil dilation, meaning your pupils get big, opposed to pinpoint. That is another critical thinking telltale that can help you figure out what's going on. Insomnia, huge. And then this is the autonomic things you need to look for because, again, central nervous system, and that's affecting your brain. So these are the things that are going to be glaring. Hyperactivity, tachypnea, hyperreflexia, tachycardia, sweating, hypertension, hyperthermia. So these are things that are often happen, and a lot of yawning, very abnormal. It just is continuous, and that'll tip you off. Next slide, please. So one of the scales that can be used is the CAL scale. This scale, and this is particularly for obviously inpatient, outpatient, 11-item scale. And it really assesses the level of severity of common signs and symptoms of withdrawal. Of course, it's on a Likert. And so the information from the assessment helps to determine an individual withdrawal management and recovery plan. This is a wonderful tool, but I will say to you, out of all the validated tools out there, and there are tons of them, the literature, they love a lot of them, and well, actually they love all of them, and they have better recommendations than others. However, what they have set with is that, have they set on one tool that is 100% across the board? No, because getting a qualitative and a quantitative validated tool is tough. So that's why there are so many out there. But this tool, to me, which is why I've recommended it, is the one, if used correctly, will tip you off if there is a potential withdrawal scenario, coupled with looking at the medications presently and past meds to see if the med recs are correct. So the CALS is something that can be a safety net for you to ensure that someone won't go with withdrawal as they're being admitted into a nursing home, maybe from a hospital. So those are the kind of med recs looking at that you don't want that missed, because we can have a withdrawal and then a death, and we don't want that. Next slide, please. Naloxone. So we know about naloxone, and as it's becoming more, I guess, people are becoming more aware, there are still challenges with naloxone, particularly with policy and procedures, and training distribution has been my experience as of late. So I'm going to give a little overview about naloxone. We just have a couple minutes. I'd love to hear from you as well. So opioid tolerance, dependence, and addiction are all manifestations of brain changes resulting from the chronic or sometimes just long-term, not so much as chronic, meaning 3-6 more months or more, opioid abuse. So the opioid abusers struggle for recovery is in a great part of a struggle to overcome the effects of these changes. So what it's saying is that we're asking them to not have the medication, and their brain is actually recovering. So medications such as methadone or LAM, bupropion, or naltrexone act on the same brain structures and processes as addictive opioids. So this is the difference with the protective or normalizing effects, meaning there is a coding, if you will, that if they're used in conjunction, particularly with naloxone, the coating on the naloxone has the ability to reverse it. But it's really dealing with the brain structures and not the behavior. So that's the beauty of naloxone. We reverse it, we save a life, and then we deal with the other things we need to deal with. So it reverses opioid abuse, or overdose rather, attaches to opioid receptors and reverses and blocks the effects of opioids. So I'm thinking here is probably the mu receptor. And that's what that drug is. It's dealing with the clinical piece, not the behavior, not the stigma, not the dependence, not the withdrawal, right? It restores normal breathing. That's what we want to do because our mu receptor just told us to stop breathing. So we just want to we want to get back up, right? And it's safe to use. There is to date no evidence out there that naloxone is harmful to anyone. So with all that being said, it really is something that as a community, as people who are in healthcare, we got to push it. We got to push the policies and procedures because that's the roadblock at the moment. To get this out there. It'll save lives. The beginning stats that I gave you, the 365,000 people that are going to end up in the ED between today and a year from now, and think about 91 of those a day being killed, we could probably save a lot of those. So take that away and to your organizations as well. Opioids include, as we know, just to reiterate, heroin, fentanyl, oxycodone, hydrocodone, codeine, and morphine. Those are all under opioids. Next slide, please. So there is a message of hope here. Public health communication about stories about substance use and misuse, overdose, and overdose prevention. Personal stories can also help influence people think, react, and feel regarding opioid use. That's the key word, feel. I think it's easy to think and judge and not feel and listen with our heart and the story of why we're here, right? And then words matter. Words, I can't tell you how much words matter. And I hope you potentially come back to some of the superior health motivational interviewing would be my suggestion because every word matters. It's so sensitive with the patient. Build a relationship of hope and resilience through communication, non-judgmental and patient-centered. The stigma, again, shine a light on stigma. Here is the HR or QR code. Please take a look, sign it. This is going to come from the community as I see it on kind of a policy side as well. It's going to come from us saying we're here and we need this. So I thank you for your support in this. I hope you've learned something that maybe you didn't know before and a different understanding of why this happens. And it's not necessarily a choice for our patient population. So entering this world with compassion and love and clinical thinking is key to mitigate unnecessary ER visits, deaths, overdose, withdrawal, etc., etc. In summary, tolerance occurs rapidly, meaning people can get, if you will, addicted or dependent quickly. Some literature says 36 hours. Overdose is often related to respiratory depression. Be aware of and look for signs and symptoms of overdose. That's what we can do if we don't have naloxone in our back pocket in a nursing home. Everyone, it's the first thing you need to think of, right? And ensure medications are administered and prescribed correctly, particularly in nursing homes as well. It gets busy, really busy. So caution, do your double checks if you're not sure, ask someone, be present, and take care of these people with the utmost dignity and respect and care. Thank you so much for letting me have this half hour with you. I've really appreciated it. If you have any questions or you ever want to shoot me an email, please do.
And feel free to put any questions that you might have in the chat. Otherwise, Rachel has left her email address available if you do want to specifically just ask her personally something. I guess, Rachel, I had one question as you presented to us. As you've worked or been in this line of work, are you seeing more overdoses occurring in nursing homes? Is that becoming, when they come from the hospital, is that something that in your research you are seeing more, or anything statistically on that you could provide?
And what I will say, without giving hard numbers, I read a lot, so I can give you just kind of the tone of what I'm reading and seeing, without giving a big data point. It has, and what I will say to that is that I believe prescribing has been much more thoughtful. There was a lot more guardrails put up for prescribers, I would say, in the last 5 or 10 years, particularly ones that work in a state like I do, Tennessee, that has, I think, we're in the top 10. So I think that is the impetus of why that happened. But moreover, and again, it comes down to regulations, policy, procedure. What I am seeing a lot of is opioids coming in through the front door and other things that say are legal, meaning, I don't know, THC, for example, here. So things are getting mixed in and opioids are going in. They may be a straight opioid, meaning they're not bad, but it happens to be in that, and that patient happens to die because the dosing was not obviously correct. So it really kind of morphs into a bigger topic, but that's why I've changed my talks to where everyone, I don't care what your title is, everyone needs to be aware, because it's coming in so it's kind of astonishing what's happening in nursing homes around the country. So just be really aware. In doubt, naloxone. You're not going to hurt anyone. I've given patients that were hypoglycemic naloxone because I didn't know. I didn't know their sugar was 40. But it could have been sugar. It could have been, drugs. It could have been opioids. It could have been anything. It could have been. So that's why the push for naloxone is really needs to be. Yeah.
Superior Health also has some amazing resources out there, and on your screen you'll see the QR codes. There's like a resource page, a one-pager that has resources that you can go to. Some of the things are like where you can find naloxone in your state, just common references about opioid usage. So be sure to head out to the Superior Health Quality Alliance website and there's some very, very good, valuable resources out there. Also, this does vary by state, but I know in Wisconsin, if you are a healthcare provider, they did recently pass a law that you can go to a pharmacy and obtain a Narcan to have on your person as a provider, as a healthcare provider. So I don't know about Tennessee or some of the other states, but that is something that recently happened in Wisconsin. So
that's music to my ears. I love that.
Yep.
That's great.
I would just add too, if you are looking for some support related to naloxone policy and procedure, we do have a particular resource. It's got policies and procedures. It's got competency checkoffs for naloxone that you could use with your licensed staff. So really, can kind of help maybe bolster some processes and policies that you already have in place. So please feel free to take a look at those.
Any further questions in the chat? Otherwise, we just ask if you could take a minute of your time and fill out the evaluation. The link has been posted. And again, feel free to reach out to a QIO at Superior Health, Quality Alliance, or Rachel has also provided her own personal email for any specific questions you might have of her from today's presentation. And I thank all of you for attending. And I ask that you look into signing up. Our next and final presentation will be how to care plan and care for residents with an opioid use disorder in nursing homes. And that will be held on Tuesday, July 23rd at noon. So, all right. Thank you all again. Have a wonderful day.